objectives are, as you heard, this session will be recorded, and we'll start now. So our overall learning objectives are to develop a virtual platform for leadership skill development, mentorship, and networking for EM leaders, to design and implement innovative programs to support EM leaders in a variety of formal and informal leadership roles at any phase of their careers. So hopefully you've been able to meet those objectives with the previous 3 sessions, and we'll continue to build on those objectives with this session. And then our specific session 4 learning objectives are to 1, recognize that stereotypes and implicit bias are common and can be associated with diagnostic and management errors. 2, apply practical strategies to support the retention and promotion of physicians from groups underrepresented in medicine. 3, identify existing resources and strategies for future learning about anti-racism and anti-colonialism practices. 4, engage in active allyship approaches to support colleagues and learners. And 5, we hope that you have fun with us today and learn a lot. And that's the end of my intro. So without further ado, we will get started.
Sorry about that. So what I'm going to talk about a little bit in this very brief plenary is to really think about and get you to really think about what is critically conscious leadership for greater equity, diversity, inclusion, anti-racism, decolonized practice in emergency medicine. And, you know, the rallying concept that I want you to really think about is a leadership of solidarity and advocacy. And I hope that we will get there through the few slides that I have to show you. I have no conflicts of interest to declare. And I want to start with the case of Mamadou. Okay, so Mamadou is a 14-year-old boy. He's from, I'll give you where he's from in a second. And he's had school problems for 6 years. And he, you know, in the past was referred to child psychiatry to rule out a mental health disorder or a developmental disorder, but this was never followed up upon by his parents. So now he's 14 and he presents after an attempted suicide. It's actually a hanging injury that he presents. So I want, you know, this is an audience from all over the country. So for those of you from Montreal or who have a little bit of a knowledge of Montreal, what would, and just put it in the chat, what would immediately come to mind if I said that he was from Montreal Nord? What would immediately come to your mind? And I will also say that for those of you who are a little more familiar with the Toronto region, we will use the Jane Finch corridor. And for those of you that maybe are a little bit more familiar with Halifax, we'll say the North End. What comes to mind? Rough neighborhood, low SES. Did any of you racialize him to a Black kid? Racialized community, okay. And I think, you know, this is the part where we talk about implicit bias, because I actually don't like to over talk about implicit bias in EDI talks. I think you need to become aware of your implicit biases, but there is so much more to leadership for good EDI. So, you know, what you did there is I gave you a neighborhood and you imbued on him maybe even a little bit of a backstory. You know, maybe, and we didn't get a chance to talk about it, maybe you judged a little bit why he never ended up in the psych referral that he probably needed several years ago, and that what you are seeing is really like an outcome of that. And, you know, even though you may not have wanted to say it, you probably racialized him. The neighborhoods that I gave you are neighborhoods where there's a high Black population, for instance. You know, Mamadou for me means someone who probably speaks French or goes to French school. Okay. So we're going to go through this case as we get to different parts of the talk. what I want us to really think about is leadership, social justice, and the Hippocratic Oath, the Hippocrates. So there is this version of the, like, a Greek translation of the old Hippocratic Oath, which is often used, like one of the points that's often used to sort of say, concern for health equity has always been there, and is part of the profession from its inception. So here's the statement. Into whatever homes I go, I will enter them for the benefit of the sick, avoiding any voluntary act of impropriety or corruption, including the seduction of women or men, whether they be bond or free. And the translation of what I'm writing there, what was written there, is basically, for me to be a good doctor, if I go into somebody's house, I'm not going to sleep with the men and women in the house, even if they are slaves. Okay. And I think that's pretty good. That's a good starting point. But I think there's a little bit more to it than that. And, I think one of the tensions of our times is really the question of whether it is in my professional obligation to actually question the institution of slavery. Like, is that part of my professional obligation? Is that what I should also be doing in this case? And I think you can maybe relate. There's a lot of tensions that occur in emergency medicine that way. And, when I sort of reflect on medical professionalism, it is a pedagogy of privilege. Doctors get privileges at hospitals, and it's often seen as a social contract where, because of the skills that doctors have, they have duties, fiduciary duties, but they also get an elevated status for that. And I think that really ignores that physicians are beneficiaries of healthcare systems that are designed explicitly to discriminate and to be inequitable. So I think in that setting, we have to reformulate what it means to be a professional, what it means to be a leader within a profession such as emergency medicine. When I, one of the earliest times that I sort of saw this was about 12 years ago when I went to Australia. I went to a conference in Australia. It was a medical education conference in Melbourne. So, I show up to Australia and it's an amazing place. It's outside looks really different than Canada, like there's not too many bodies of water. There's a lot of sun and a lot of dryness. And there were these massive flying foxes in the trees that looked to me like puppies with wings. And, I was sort of thinking, well, it's going to be a really exotic place. So I show up to this conference, and at the conference, they're talking about distributed education across the vast northern wasteland. And they used words like wasteland. And that was like, wow, that's the kind of thing that we would say at CCME here in Canada. And then the pediatricians are sitting there talking about the rate of otitis media in Indigenous children. And Indigenous children, just like we do in Canada, and in Indigenous children could not be more separated by climate or genetics. And I guess what happened to me in that moment was I realized and understood on a real visceral level how colonization can be a determinant of health, and how that can translate into a really granular observation. In Australia, where there are also King Streets and Queen Streets, and where there is, everything in Melbourne was done in the name of Queen Victoria, just like Montreal, and where the observation of otitis media risk is the same. So really understanding colonization as a determinant of health. And that was one of the moments where I sort of vowed to bring that into my teaching, actually. And, what is that all about? That's about equity. And that's about the recognition of a historic and ongoing systemic marginalization or discrimination that is experienced by specific groups. But more importantly, it's about understanding our institutions as key tools in the colonization process, or the process of systemic racism, for instance. Bryan Sinclair and Joyce Echequan, were cared for in emergency departments. And, I think that is for us to reflect and own and understand to get better. I've been around the teaching of culture for a really long time, since 1996. And I sort of have these three metaphors for, the beginning, the midpoint, and now. And I use the metaphor of a still life painting. So in 1996, I would have said, look at the beautiful colors in this still life painting. I'm going to try and teach you to appreciate those colors. And that was good. I was trying to teach you cultural sensitivity, but that was so wrong because I taught you to be blind to power in relationships. So then around the midpoint, let's say 2008, 2009, there's this painting. And that is, look at the pretty colors in this painting. And by the way, some of the fruit in this painting are exotic. And maybe to appreciate the coloring of that fruit, I have to shine a different light on it. And the idea of that is to teach you the competencies required to care for a diverse population. And that was an improvement for sure, but it kind of gave you the idea, or gave me the idea, that you could know everything. And, enter 2021, and I think that the statement would be very, very different in 2021. It would say, what kind of painting is this? Is this an abstract painting or an impressionist painting? And because of that logic of that painting, why does that make us paint pairs a certain way? Why are some colors in the front and the back? So I don't think that ethically we can teach about social diversity without teaching about structural determinants of health and the collision of those that occurs within the emergency department. And the rallying phrase that I use is, this appointment was booked 400 years ago. And this comes from the cultural safety paradigm that was promoted and developed by Maori nursing educator Iria Petty Ramsden. And what she did that was revolutionary about the doctor-patient relationship was she situated it as occurring within a history. So she situated it as occurring at the Treaty of Waitangi, which is to New Zealand what the British North America Act is to Canada, the founding document of New Zealand. And I thought that was really revolutionary because she got us to ask, why this patient with this disease in this social context now, and how is that happening? And I think that that is a key kind of skill that you need to build. So when we look at Mamadou now, we have to sort of say, why didn't he have his psych referral? It turns out that there is a 35-page intake form to get the psych referral. Like you get the referral, you have to phone the psych clinic, and they won't accept you unless you fill out this intake form. And this intake form asks you lots of questions, intrusive questions that help them decide which clinic you're going to go to. And it's written at the grade 11 level in English or French. So Mamadou's parents do not speak French to that degree, and they experience a barrier. So it gets us to ask more deeply about that. And I think the real skill that we're trying to build, and this is critically conscious leadership as well, is the idea of critical consciousness, which comes from Brazilian educator Paulo Freire. And really, he wrote a book called Pedagogy of the Oppressed. He really recognized individuals as conscious, reflective social beings who could be aware of social contradictions and injustice, and then have a commitment to act. So the two skills that we really need to build in leaders is structural competence to read the world. Why is that intake form built that way? It turns out that there's a primary research purpose to that form when you look at the history of it. And then committing to act to change at the meso, macro, or micro levels. And I think that what we need to understand is, what kind of painting is this? What is the logic of this painting? So this painting, the medical systems of Canada are, and everything here has evidence, it's not me talking through my hat, are that it's racially hierarchical. There's anti-Indigenous racism, there's anti-Black racism, anti-Semitism, like a legacy of that is in the ether, and lots of multiple anti-brownnesses and Islamophobia. It is also patriarchal. When we teach that women present atypically with symptoms of MI in comparison to men, of course, we're going to notice differences. in treatment and outcomes. It is heteronormative and transphobic and ableist. And these are the things we need to root out as leaders. So what is colonizing versus decolonizing leadership? This is a picture of Bartolomé de las Casas, who's one of the early conquistadors, and he's complicated. He was sanctified, but he was also one of the conquistadors, but he also tried to protect the Indians that he ran into in Mexico. And I think that colonizing leadership is one that recognizes that we are within structures that make us exploit, whether we like it or not, and that we have to act differently. And also that says, I don't have this, that doesn't say I have the solution for you, but really asks you, what do you think the solution is? Let's share our expertise and try and get the solution to the problem. And how do we do that? We do that through engaging in deep listening, which is listening that is attentive, generous, and trusting.
Sorry, Dr. Razack, that's your 1 minute warning.
Thank you. As trusting and willing to live in ambiguities and uncertainties. So we are aiming for a critically conscious leadership of liberation and solidarity, where we act with and not for and on populations and learners and colleagues in an empowered way, dialogically. So this is the last slide, so I will finish. What is the major objective of a critically conscious leadership? Is that when Joyce Echequan's tragedy happened, resist the urge to say that the system dysfunctioned and there were a bunch of bad apples, pommes pourries. Really, the system functioned exactly as it was designed to do. And that is what we need to teach leaders, to have the skills to recognize that and then to commit to act to dismantle. So I won't do this slide, but I'll leave it for you, and I will say thank you.
Thank you so much, Dr. Razack. I'm still curious about what that last slide means. We're going to transition now to our breakout room. So we're going to divide you up into 3 different rooms. We're going to talk about some specific cases and then come back to the large groups. So Rob, Caroline, do you want to go ahead and divide us up?
Okay, I'm going to put everybody in rooms, and then I have to find myself into room 2. So hopefully I won't get lost.
Sorry, Rob, are you going into room 2?
That's what I want to do, but I don't know how to get there.
Yeah, I'm going to assign you. Hang on. You're going. I don't know. There you go.
I'll put up those resources again as the rest of the groups are joining us. All right, just giving everybody a moment to come back from the breakout rooms.
I think everybody's back.
Are we back?
Yep.
Perfect. All right, so this is going to be a chance for our groups to share a little bit of their discussions. Unfortunately, the whiteboard does not seem to be working for me right at the moment, so we'll just have a conversation. So let's look at the different groups. So for group one, which was the group led by Connie and Darlene. Anyone from that group able to give us a 2-3 minute summary of your conversation and just in brief what the case was that you were discussing?
Yeah, I took notes for our group. So we were discussing recruitment, specifically in the case scenario where, you know, the age-old excuse of no one applied. We don't have people that have the training to fill this job, so that's why we can't get diversity in these leadership roles. And so the breakout group was just discussing strategies to achieve diversity. And so the first one that was brought up was to mentor people. So the recognition or the act of recognizing somebody who's showing interest, to show interest in them, offer them some opportunities so that when a bigger opportunity arises, they have the confidence or experience to step forward. And then that kind of blended into sponsorship, like putting your name out there for somebody and backing them. And we then discussed kind of how and where we post jobs. So the idea was raised that you're only going to get basically people that you post the job to. So think about who you want to recruit and therefore where you're posting your job. There was the suggestion to reach out to community to find out who their community leaders are and disseminate job postings through those communities through the leaders who you may not be aware of. As well as the language of job postings. So it was brought up that if it's written by the person who had the job previously, it's probably going to describe a lens similar to the person who held the job, but may not reflect, everybody may not see themselves reflected in that. So a second set of eyes or an alternate set of eyes to look at the description of the job so that it appeals to a diverse set of applicants could be another way to get more diverse applications. And then the suggestion was made to maybe, at least for internal hiring, to at least know internally who's going to represent what group and, you know, demographic data on various underrepresented groups. And then there was some talk about how we try to expand our thinking. And so rather than seeing job postings as a certain technical skill set, try to see diversity as a creative problem solving and to see strengths rather than see a deficit-based lens that we often use.
Excellent.
I think that was most of what we got.
All right, thank you so much. So a lot of very good practical ideas and suggestions that I think some of you are using already in your processes, but if not, maybe some ideas to adopt there. Let's look to group two. So that's Rob and Huma's group. So who would like to speak on behalf of that team?
Hi, Jen. It's Mita.
Oh, Mita.
I'll be speaking on behalf of our team. We raised quite a few different points. One was initiating some kind of root cause analysis for why women in the department aren't applying, trying to identify if the barriers are different for women and men for applying for leadership, and we know they are. So how do we change those barriers? Someone raised a question if they were willing to change the description of the job to permit the destruction of the barriers. Promoting more women in leadership. So, sponsorship, mentorship, as has already been discussed, and representation. It's hard to be it if you can't see it. Words from my good friend Joan Chang and others, I'm sure, but representation does matter. And then someone asked, if the job could be restructured to permit domestic responsibilities of which women share in many households, so lions share. And if women are the breadwinners, could the job be restructured in a way to permit pursuing a leadership opportunity while maintaining their income? Rob mentioned that women are hired for track record and men are hired for potential. So keeping that in mind, that there are those biases present. And then finally, ensuring that your hiring committee is equitable. So knowing that you're getting hopefully a fair chance by having a hiring committee that is diverse and representative of all groups, knowing that you're going to get a fair chance at an interview would maybe promote someone, or would maybe push someone to actually go ahead and apply for the position.
Excellent. All right, thank you. So some echoing of themes between the two groups, certainly. Hey, yeah. All right, and then my group with Saleem. I think Michelle, you're going to speak.
Yes, great. So we had a discussion a bit about the interview process and a little bit about setting things up in advance so that you've got clarity around the process for the interviews, both for the interviewees as well as the interviewers. What the specific process for it. Discuss in advance sort of what is in scope and what is out of scope to discuss, so that you then set up specific questions that everybody is asked, but also as part of the discussion, because that's sometimes where the creep comes in, that you might start discussing other things. So what is in scope to discuss? Because sometimes you need to exclude discussions of other things. The committee themselves ideally would have a broad idea of what you're looking for. So, but that also includes thinking about bias. And so including something like having people participate in or complete the Harvard implicit bias test, or take the Stanford course on unconscious bias in advance. So then set up that discussion, straightforward questions of what you're looking for, and that can be based upon how you identified excellence. So the criteria, I thought that was an excellent idea from our group. So the defining what is excellence will help you for the discussion. Because if you don't define it in advance, you can change that at the end. I really like this person, therefore excellence is this person, rather than other qualities that you may not have thought about, but as a group you could define. So I think that that's great. And in our question, it talked about, use the word fit, this person being a good fit for the job. And so we talked about the culture of the interview, so that everybody that's an interviewer could feel comfortable asking, what do you mean by fit? Because that can be a really loaded question. And the idea that I would agree strongly with, that saying somebody isn't a good fit is sort of a recipe sometimes for choosing people that are only similar to you. You would end up with a less diverse group, potentially, if you talk about fit. So perhaps not the best word, but perhaps it was meant in a very innocent way, and simply by exploring that. So do you have a culture in the room that you could explore that with the other people that were interviewers? So thank you, Jennifer.
Excellent. Thank you, Michelle. All right. So again, some very practical suggestions that hopefully you might be able to use the next time you're organizing an interview committee or sitting on one yourselves. I'm going to turn things over now to Dr. Darlene Kitty. I have been looking forward to this talk, and so I'm going to mute myself and let Dr. Kitty take things from here.
Hi, everyone. Just going to load up my screen here. Can you see it? All right, so my part for this session is to look at existing resources and strategies to learn more about anti-racism and anti-colonial practices. So, as you know, Dr. Razack had mentioned Joyce Echequan, and there's been a lot of momentum since she unfortunately passed away so tragically in a Joliet hospital emergency room. And I think we're all on board here to advance anti-racism. That's why you're here today. So how do we, use our leadership skills to advance anti-racism in the emergency departments, in our medical schools, and other places? So of course, there's different types of racism. We have, individual or systemic racism, covert, overt, unintentional, intentional, relational, structural racism. And there's other terms kind of along the continuum of racism, stereotyping, assumptions, prejudice, and discrimination, words that you've all heard. So how does racism develop? So we have this, this graphic that I'm showing that looks at unconscious or implicit bias, as mentioned by Dr. Razack, that we're really unaware that this is in our minds, how we make judgments or assumptions about people. And, I think we all have this. We should be constantly self-reflecting on this to avoid making wrong assumptions and decisions based on the person in front of you. So eventually it can lead to overt behavior against a marginalized or racialized person. So, and this can lead to even stronger behaviors or outcomes that leads to discrimination and eventually to systemic racism. So of course, to deal with this, there is the implicit bias or unconscious bias training that's been mentioned earlier. Here's a stereotype. Many people think of Indigenous people as down and out on the streets in Vancouver, shooting up drugs, walking around drunk in downtown Regina, and then there's Bryan Sinclair, as you all have heard of. So these are unfortunately the most visible part of Indigenous populations, the most negative portrayals of them, when probably this is actually the minority, because most Indigenous people, do fairly well in life, or are happy living their lives, in their community, up north, on the land. Sometimes they come to urban centers for health services that they can't get in their community. And so it's important to realize, this is not Indigenous people, this is the minority. And here is what we see, up in Northern Quebec here, we really hold strongly our culture and traditions. So the Crees, many families have these freighter canoes. So here one evening, a bunch of guys, there's a couple of med students there, they're going out for a canoe ride on the La Grande River. There's me with an elderly patient, a family with a newborn baby, and some Crees up here on the top right are dancing to fiddle music, which was adopted into the Cree culture through the exposure to Hudson Bay workers, Hudson Bay Company workers when the fur trade started. So this fiddle music and square dancing still is strongly part of our culture. So that's the beauty of Indigenous peoples. This is the positive stuff that we should learn and appreciate, and it gives our patients strength and resiliency. So what can you do as an emergency room physician? Obviously, starting to learn about Indigenous cultures, racism that affects their health, residential schools, for example. It's important to understand this history and the realities, and then you can act and advocate whenever needed. And part of this work also, you need to involve Indigenous leaders and communities. You can't make decisions for them, but you need to appreciate that they could help you develop better services for this population. In downtown Montreal, for example, you might reach out to the nearby community of Mohawk community of Kahnawake. And we need to look at it at multiple levels, at the individual level, in your clinic or department, at the medical school, and broadly more at the hospital and organizational levels. And it's not just a short-term solution. You need to find long-term strategies to change behavior. So when we start to think about these strategies, we should start with cultural safety, and as it's been mentioned, we have to think about that history and other contexts and that power relationship, instead of a doctor up here and a patient down here, it should be really an equitable partnership and building good relationships that are trusting and respectful. And that's a two-way street, So Indigenous patients can feel safe when they're interacting in the emergency room. And this also involves cultural humility. So we need to self-reflect and consider your own values, beliefs, and attitudes, because it's certainly different from that Indigenous culture, or perhaps, a culture of a person of color or a Black patient. And what is it like to be in their shoes, where they live, what they do for a living, what impacts their health. And most importantly, you need to learn. You need to recognize that, yes, you need to learn these things. So some strategies at the individual level, get to know your patient population. So in Montreal and Ottawa, there's a significant Indigenous population. So you need to understand which groups are there. And there's many groups, obviously, but also consider they have probably a common history of residential schools and other social factors that affect them. What's the realities of their community? And then there's the other groups like BIPOC groups. So also realize, as I mentioned, there's diversity within a group. So some patients, like Cree patients, will do well in life or are educated, have a good job, and some really struggle in living on the streets in downtown Montreal. So there's everyone else in between. So you need to think about what's it like for this person sitting in my emergency room. How can I help them? What supports do they have or what they don't have? It's important to create a good therapeutic relationship that is safe and trusting. And sometimes that means chatting a little bit with them. So giving a little bit information about, yourself or your team, and perhaps learning a little from them. And that can build trust. Also making good communication with them, listening. Listening is very important, and explaining in good language, not using too many big words. I use an approach, this is what I'm thinking, so if someone's in with hyperglycemia and we're doing some lab tests and, I have to adjust some meds, perhaps I'm explaining to the patient about their medication, and I'll say, this is why we're doing this, because, you have high blood sugar. We need to treat that right now with fluids, but we're also going to change your medicines, and I'll explain a little bit about the medicine. And this is what I'm thinking, so we can help improve your diabetes control, and then you will have follow-up, So using a strategy like that will help. And then ask if they have questions, because sometimes they won't ask. they'll just kind of absorb what, or maybe they don't even absorb what you're saying. So it's important to give them an opportunity to ask questions. And really that will help create a good partnership in their care. For the clinic or department, you know, I'm just thinking, you know, since Joyce Etchquan's death last year, there's been a real good momentum in many organizations, College of Family Physicians and CAPE, and people are, you know, getting on board for anti-racism, and it's great to see. So capitalizing on that motivation is a good time to, you know, address it in your clinic or your merge department. And like Dr. Razack mentioned, the implicit or unconscious bias training is a good way to start. I've done this at the University of Ottawa Faculty of Medicine, and it's, you know, even I learned some things, you know, that I didn't really think about before. And I've been a nurse and then a family physician for years, and I probably could have used some of that information, you know, to have more effective interactions with patients. Because I'm always learning about other cultures, not only my own culture. Anyways, here's a biggie: mandatory cultural safety training. So I think this is really important. Some hospitals are doing this for their health professionals, and you know, there's the BC SANYAS training. There's an Ontario version that's available, and there's other online resources as well. Included in that, it's not just more, you know, didactic. I think you need to connect that cultural safety training with patient stories and lived experiences, because then it will have a better impact, you know, for you to consolidate that knowledge. And I always say, you know, for reconciliation, your journey starts with knowledge. Well, this is a great way to start cultural safety training. Sometimes there's difficult dialogues, you know, and we talk about white privilege and the power differential that needs to be disrupted. And, you know, medicine is full of these kind of, you know, dialogues that need to happen. It's very paternalistic, very colonial, and, you know, the healthcare system as well, and in society. So we need to approach this with a good intention to discuss it, expose it, and then dismantle it. And that goes along with systemic racism, like these difficult stories of Joyce Etchquan and Bryan Sinclair. And then with all that, you know, you can repeat all this, you know, there's turnover in staff, and, you know, over the years, it should not just a one-time deal. We're going to do it this year and then we're good for a while. No, you have to have ongoing teaching and learning. I think that's the best way to keep the momentum going. So in medical school, you know, basically anti-racism has only been, it's not taught very well in medical school, at least when I went through, and it's only become a hot topic recently because of the unfortunate death of Joyce Etchquan. But it's good time to build on that, you know, start developing strategies. And basically at medical school, the same strategies apply as if, you know, it's a clinic or a hospital. So the other thing is, what else can you do at the medical school? Well, have anti-racism on exams. What about accreditation? Is there an accreditation standard that includes systemic racism as a topic? And what about professionalism? How does the policies of the medical school consider anti-racism or other you know, negative behaviors like harassment or intimidation? So that's a question that you know, we can think about because many of us are still involved with medical schools, and some of us are, you know, residents, some of us teach at the school or have administrative positions. So there's still opportunity there. At the hospital or organizational level, you know, you really need leadership buy-in. And I know at Ottawa U, my dean is really on board. There's been a lot of activities in the past year. And at CAPE, we have the anti-racism, anti-colonial working group, which I'm proud to be a part of. In the hospital, you know, is there a welcoming atmosphere for Indigenous or other groups, other patients? You know, even having cultural elements in the decor could help make patients feel comfortable and not so sterile an environment. You know, hospitals are pretty white or green walls or, you know, beige. At the Ottawa Cancer Center, they have an area for Indigenous patients and their family members. So when they come there for their treatments, they are welcome to come and sit in that area. There's some couches and art on the wall. And there's a patient navigator, an Indigenous patient navigator who comes to visit and supports those patients while they're there for a few hours. So maybe we need that in our hospitals somewhere. Maybe some hospitals already have this. There's also needs to be a policy on supporting anti-racism or zero tolerance. Maybe it might not be so clear, but it certainly should be there in black and white print, you know. And is there a reporting mechanism? So something to ask of our human resources departments. This has already been mentioned in the cases about recruiting and retaining health professionals from diverse backgrounds and orientations. So we would encourage and support advancement and find mentors for anyone who is interested. So sometimes that just means a conversation over coffee in the lunchroom. You know, how would you find out that someone could be interested in a leadership role? And you can't do it all by yourself as an organization or a hospital. You need to engage Indigenous leaders and community resource persons, you know, like perhaps a nurse from the community to make that link. You know, when you have patients seen in the emergency room and they need to go back to their community, how do you connect them? You know, sometimes it's just a piece of paper, but sometimes it might deserve a phone call to a social worker to help, you know, with sorting out that Indigenous patients' problems. And this applies to other persons of color, of course, if they have community resources. So, you know, some of the resources might include a patient navigator, as I mentioned. There might be community agencies like a friendship center. As I mentioned, the health clinic or staff in the Indigenous community. And what might help to drive improvement in health services is data collection and research. But of course, sometimes that's difficult with racialized groups, and that probably deserves another talk at some point. So just finishing up, resources can be found at the Royal College of Physicians and Surgeons website. There is an Indigenous web page. There's two resources here: Indigenous Health Primer, which explains more the basics of Indigenous health issues. And then there's Indigenous Health Values and Principle Statements. This one is looks at the CanMed's competencies and applies an Indigenous lens to it. So it's nicely written and can be used for teaching and also, you know, assessing your competencies and how you can help Indigenous people in that context. And then the College of Family Physicians, we just launched Indigenous supplement to CanMed's FM 2017. I helped to co-author this supplement, and we're very proud that it has competencies with that Indigenous lens, and anti-racism definitely in both those documents. There's another fact sheet from the Indigenous Health Working Group, which is us before we became a committee. So that's a short read. And then there's one thing I found online. This is American paper, Toolkit for Teaching About Racism in the Context of Persistent Health and Healthcare Disparities. It's a nice document, about 50 pages long. It has facilitation notes, a list of resources with, you know, papers, activities like exercises, videos, websites. So you can use this for teaching and discussion, you know, to help address anti-racism and you know, create action in your department or your hospital. Some more anti-racism documents from the National Collaborating Center for Indigenous Health. And then I'll just leave you with one last thought. This is the vision for Indigenous health and care from the Royal College Indigenous Health Committee. So they aim to create healthcare that is free of racism, where every Indigenous person is treated with respect, recognized as an individual rather than a stereotype, and experiences the highest level of health, and that all stakeholders understand how colonial structures and systems link to current health inequities. And oh, that's my references for my resources points there. And that's it. Thank you very much.
Fantastic, Darlene. Thank you so much. A ton and a half of resources there of use to all of us. We're just going to look at some of the best ways to share those resources so that everybody can have access to the list that you've provided. I'm going to turn things over now to Connie. So Dr. Connie LeBlanc, who's going to be talking with us about micro and macroaggressions and allyship.
You're on mute, Connie.
People have been trying to shut me up for years. Darlene, thank you. That was wonderful. So I have this slide up to remind us that I'm going to give you examples of micro and macroaggressions, and some of them may be triggering for some people. And so they're in no way meant to offend anyone, and just so that we're kind of all on the same page. So next slide. So microaggressions are casual racism. So things that we could do very easily. They're not intentional, and they will have some examples of what they are. Unlike overt discrimination, what they do is they're little insults that happen every day to people who are from minority or diverse groups. So just those little things that happen every day and collectively have a significant impact. And they impact the way you feel about yourself, the kind of energy you bring to your work, and how you can move around in a space. Next slide. So things like, you're the whitest Black person I know. And that's intended to be a compliment, but it's not lived as one. And so the person saying this may say something also like, oh, your English is so good. That can be really lived as an insult. And and microaggressions, the same comment to two different people will be lived differently. And that's why they're so tricky. So next slide. My husband's Chinese. That's why I'm vicariously Chinese. When he was in grade 2, they were lined up and asked to count their aunts and uncles. Any of you who have hung out with any Asian people, you know that they call everybody auntie and uncle. So when he got to around 97, his last name's Chan, 97 aunts and 100 uncles, and the person before him said, I have no aunts and 2 uncles, he realized all of a sudden something isn't quite right. And he just made something up and went with it. But when you think about the little things that people cope with when they are from a different culture, when they are from a different background, the little things that they have to adapt to every single day, all along their path. And the fact that they've been able to overcome those is exemplary, and means that the same person who will look the same way as another person who is not from that group has actually endeavored more. So just when we think about it in that way. The next slide. So your English is so good. Where are you from? Where are you really from? No, where are you really from? People hear this every day. And, where are you from to me doesn't feel insulting, but to somebody who has an accent or who is a new Canadian, that can feel like an insult, or who doesn't maybe look like patients expect, that can feel like an insult. And so the same comment, again, can be a microaggression. Next slide. So we just published this paper, 4 of us, on dealing with calling out racism and a achieving allyship. So allyship is standing alongside people and moving through life with them. The QR code takes you to the paper. It's in the Canadian Medical Education Journal. And we had 6 steps of being, so recognizing who we are, where we're from, knowing the history and the culture and where other people are coming from, acknowledging that these are hard things. They can be very hard. And so for people who've had privilege, losing privilege can feel like persecution. For people who haven't had privilege, trying to gain it can feel like theft. Doing things, so acting and promoting and changing structures so that everybody's included, are part of this. And so we are going to be at different steps along this path for different facets of diversity and for different parts of our work. Next slide. So allyship is never about you. So allyship is not about the ally, it's about the recipient of that allyship. And so when you see people who, next slide, when you see allyship being about, the selfies, the voluntourism, the kinds of allyship or kinds of support that reinforce colonial structures and or that are within walls that are very tightly constricted so that you're helping people maybe fit into your frame of what they should look like. Those are not allies. An ally is somebody who strives to understand, who listens deeply, who reflects on it and supports the person who is, for whom you're serving as an ally, to be to achieve the most that they can. Next slide. When we think about Stephanie Nixon, I don't know if you've read this paper, but it's pretty awesome. It's the coin model of privilege and critical allyship. And the next slide shows that for the underside of the coin of privilege is oppression. And if we had a handful of coins, if you pulled out a pocket full of change and you looked at that, it would, next slide, look maybe like this. And you'd have heads and tails on different ones. And so we all have facets of our life where we are privileged and other ones where we're not privileged. And the mix of that is what creates those intersections that can be really devastating for some people. And so it's important to recognize the facets of our life that are like that. When we talk about the next slide is macroaggressions, so frank racism, and we just have to step up to it. We need to find tools. We've worked for years to find tools to get patients to answer the questions we're looking for. One of my favorite expressions is really. It just says it all. You just drop that and all of a sudden everything stops and people are like, what? We also have to step up when we hear racism toward our staff, toward our fellow physicians, toward our residents. It is our job to step up. It's against the law. And so we have to identify it like that and treat it like that. Next slide. Critical consciousness is the Paulo Freire, achieving in-depth understanding of the world and allowing our perception and exposure to different political and social contradictions. So kind of embracing that messiness that all of this is. It's necessarily messy. And so just admitting that. We're going to go to 2 slides down. The next one is talking about a toolkit. So what's in your toolkit to deal with this? So I use really, or wow, that sounded like, or did you really mean? They're all very kind of open, a little bit critical, but not you're a racist. So we're going to move into a couple of cases, and Dr. Huma is going to take us through those using Mentimeter. So you need to go to this address. Go ahead, Huma.
Sorry, I'm struggling to find the unmute button. I apologize. So we're going to be using Menti for the cases that Connie's going to be bringing forth. So if you want to open up a new browser or use your phone, log into menti.com and insert this code. We've got 3 cases and 3 questions. We really hope that you participate and share because it's very, very valuable to hear what you have to say and what you're thinking. So I'll hand it back to Connie for the case, and then we'll go to Menti in just a minute.
Okay, so this case is a surgeon who realizes that in his practice, he's a program director, he's a Canadian program director, in fact, and he realizes about 20 years ago that he uses his male residents as the gold standard, and he compares all the female residents to the male residents to determine if they are doing well. And so how could he proceed? How can we avoid this? And how could he proceed with this issue?
So if you want to go ahead and answer this question here, in the circumstance that Connie described, what would you do or say as a bystander to this statement or conversation with this individual? I'm going to give you a few minutes to share.
So you could be a female resident in his program and you realize this?
Huma?
Yeah.
Oh, perfect. I see more responses there. I just realized when I opened Menti, initially it went to a different slide. So if that's happening to anyone else, you should see the slide that has the picture of the surgeons there.
Awesome. I'm just going to give maybe another 20 seconds of silence just for people to reflect and share, and then I'll go through the answers. Thank you, Jennifer. Awesome. Great. Thank you so much. So what would you do in this circumstance where there's a surgeon realizing that the gold standard was male residents and you're a potentially female resident in that circumstance? So something that you can bring forth is that there really needs to be objective, transparent standards that are placed. What makes a good surgeon? It needs to be written down, reviewed with others, maybe a diverse panel to come up with what would objectively make a good surgeon. Another comment similarly, what are the objective standards you're looking for? Instead of employing his false gold standard, he should reflect on what the actual features that make a good surgeon. I think we're all sort of saying the same thing there. Can you help me understand why he is the gold standard as opposed to anyone else? I would call on this individual and be objective about what is happening, followed by my feelings and thoughts about this, and then the desired change. So really like calling out the behavior, sharing your own feelings, and then coming up with something concrete or putting forth what can potentially be changed in these circumstances. Excellent. Resident needs to be evaluated objectively on performance. Yeah, again, being very concrete in terms of what are we looking for objectively in a surgeon. Pull aside and say that is he suggesting that there are no kick-ass female MDs? Yeah, maybe even bring a new perspective to that conversation to say, this is, by your standards, this is what you're saying. Is that how you actually feel? And allow this person to reflect a little bit further. Change the definition of excellence or broaden that definition. Use subversive language. When they say, take it like a man, I say, take it like a girl. Absolutely. Bring it right back to them. Asking them to sort of just take them aback with exactly that. Can you clarify your technical expectations? Answer, okay, just to make sure it has nothing to do with sex. Absolutely. Being very clear about what the expectations are. Recognize possible power differential between resident and PD. Go to a trusted mentor for advice. Absolutely. If you're a female surgeon and you have a male preceptor in the circumstances, there is definitely power over that's occurring. And maybe you don't necessarily feel free to actually have that conversation with somebody who's evaluating you. So to find a trusted mentor. But what do I do for, like, in this particular circumstance where my evaluations might be at stake by speaking up about a macroaggression, microaggression? Consider writing out a list of what characteristics you would ascribe to a learner in any category of functioning, below average, average, superior, and re-examining these criteria to see if there is gender bias inherent in them. Again, really being very clear about what is our standard of care, and looking at it with an EDI lens. Is there gender bias in these objectives we put forth? Unfortunately, I would likely miss it and let it go. Oh, interesting. I find this very, very interesting comment because I have absolutely been in circumstances where I've missed the microaggression. I haven't had the awareness and or I've not spoken up or said anything. So I appreciate the honesty in that comment. I would ask why. Perhaps exploring would give pause to consider the inequity in the practice. 100%. Great way to approach microaggressions. The question is why? Why is this happening? And really probe that person, I think, a bit further. Connie, was that you? Really? That sounds like... Awesome. We're going to go back to the next case. Just bear with me as I switch over. Apologize.
You could tell him you were going to be a girl, Jen. It's a gold standard girl surgeon. So this is something we have a lot in our setting because we're not allowed to change the specified gender on patient charts until they have completed their transition and applied. And so their patients' health cards and medical charts retain their birth assigned sex or gender. And so pronoun mix-ups, when a patient tells you they want to be called Sarah and you continue to call them Glenn. And sometimes this is accidental, sometimes it's from inattention, and sometimes it's purposeful. And if you heard somebody doing this, what would your approach be to addressing that? It's kind of a delicate thing. Maybe you would hear a team member or a colleague, or like how would you go about, what would your approach to that be? It's a tough one. And it's something, you know, we all do sometimes.
All right, back to Mentimeter. What would you do or say as a bystander to this situation where somebody is maybe intentionally using the wrong pronoun? I'll give a few minutes. All right. So I'm going to start going through these responses. I think we can improve the patient's care by respectfully using their preferred name. Wouldn't you agree? So bringing to light what is actually going on and how we can best respect our patient and inviting them to reflect on why they're saying what they're saying. Have you asked them what is their preferred pronoun? So really bringing it back to the person themselves and say, do you know what they like to be, how they like to be referred to? I would bring it back to the goals of medicine, which are health and wellness, and ask the person if they think they're contributing positively to that. Absolutely. Again, reframing it for the person. Appropriate to correct the error, giving grace as to intentionality. Correct. I think we all make mistakes as well. And being clear that the oversight is noticed and not acceptable to the individual or to me. So saying, hey, this is not okay with me and not okay with the patient. I would speak to the person privately and point out that they need to be thoughtful and aware of the importance of trying to get the pronoun right. So taking them aside and having that conversation with them. I've noticed you using the wrong pronouns for X makes me wonder if you might have trouble with how they're identifying. Is there something else going on? Is there something else going on here? Once aware of the pronouns, write it on the chart in the EMR, etc. So really making it very clear as to what this person's pronouns are, writing it everywhere that you possibly can. I usually state that I'm not sure if you are aware, but this patient is identified as. I'm just trying to understand why you would use that pronoun in this situation. Can you explain? So coming from a place of curiosity and asking for more information. Thank you. We'll bring it back to the presentation.
So Roberto Montenegro is, he wrote a paper for JAMA called My Name is Not Interpreter. It's worth a read. That's the QR code that takes you directly to this paper. I think we're going to conclude on this note so that we have time for concluding comments. Thanks very much.
Excellent, Connie and Huma. Jessica, do you want to wrap us up for the day?
Absolutely. So I know that we have about 1 minute to spare before the official end of our session. So I'll keep it brief and just say thank you all for coming to this session. Thank you for participating. Lots of the themes that we've identified today, both by our presenters and in a group, have been about getting educated, being reflective and participating. So we're already doing the right things by going to these kinds of sessions. Thank you, CAPE, for allowing us to put on this type of session. Very grateful, and I think we all learned a lot. It was really nice to meet everybody. And yeah, this concludes the end of our virtual leadership session. So I hope everybody got something out of it, and thank you. It sounds like Dr. Sinclair has something to say, so I will let him finish off.
Thanks, Jessica, and thanks to the great presenters and team today. So this concludes our fourth series and our second virtual leadership series. As I said at the beginning of it, this is all of us learning together. So all of the registrants that joined us, you're part of this leadership journey. So you will receive an evaluation for this session, and thanks for doing all the other sessions. What's really important is a couple things. Is please give us advice on where we should go with this. This is really important. This is our kind of third leadership offering. And the other thing that certainly Eddie and I would like to hear is, one of the things we've talked about is, again, building a community of leadership practice. So please give us some practical suggestions on, number one, do you want that? And number two, what it should look like. Should it be a listserv? Give us some examples, because if there's lots of interest, we'll do it. But as you know, from being on listservs, you need someone to curate it and take care of it. So please let us know about that. We will want to build on this community. And again, as a group, we'll be getting back, talking to the CAPE board and see what might be next. So thanks, everyone. It's just, I've learned so much. It's just fantastic.